Hello, my name is Dr. Sam Richardson, and this is the lung video for the bedside review series for Mountain View Hospital. As a reminder, these are short videos for rapid review prior to performing point-of-care ultrasound and are not a substitute for a full didactic experience. The point-of-care pulmonary ultrasound is typically performed with either the linear or curvilinear transducers. Pathology we are attempting to identify includes pneumothorax, pneumonia, pulmonary edema, and pleural effusion. Please note that the linear transducer should only be used either to rule out pneumothorax or in a very young pediatric patient. When imaging the lungs, the general goal is to cover as much of the thorax as possible. At the base of the lung, ensure the diaphragm is visible in the center of the screen or just to the right of the center. It is also helpful to rotate the probe to 10 o'clock on the right side and 2 o'clock on the left side to fit between the ribs and improve your sonographic window. It may also be helpful to have the patient take a deep breath and immediately exhale. In the midfield of the lung, make sure the pleural line is flat and sharp to improve visualization of any potential pathology. When imaging the apex of the lung, the top end of the transducer should abut the clavicle and the subclavian vessels should be visible on the screen. In many cases, it may be helpful to image the lung posteriorly. Have the patient sit up and apply the probe to the thorax between the scapula and the spine on each side. We generally recommend starting at the lung bases and moving from one side to the other as you move up the chest. This entire exam is typically done with the probe in sagittal orientation. However, you may consider turning the probe transverse at any identified pathology.